we are pleased to have Stephanie Smith with us here today. She's going to be sharing her knowledge of mental health and her experience working with people who have serious mental illnesses. She's been a licensed clinical social worker since 2017. She's worked in a variety of settings, including residential behavioral health, child welfare, nonprofit sector, and medical social work. She might be a familiar face to some of you. She's currently the regional behavioral specialist for Region 8. And then we talked about remaining muted today. We do ask that everyone remain muted during Stephanie's presentation. If you have questions, and we do encourage questions, feel free to type them into the chat. We will have time after her presentation for a question and answer time. You can also go down to the reactions and raise your hand if you want to kind of verbally introduce your question after she's done presenting. So I will turn it over to Stephanie.
Thank you so much. Next slide. Thank you for joining us and your peers to learn more about mental health basics. Next slide. The Substance Abuse and Mental Health Services Administration, or SAMHSA, defines serious mental illness as someone over the age of 18 within the last year having a diagnosable mental, behavioral, or emotional disorder that causes serious functional impairment that substantially interferes or limits one or more major life activities. The key part of this definition highlights that the illness substantially interferes or limits. We often see major depressive disorder, bipolar disorder, and schizophrenia fit into this category, but those are not the only mental illnesses that may be considered a serious mental illness, depending on the degree of functional impairment or limits that it creates for a person. Having a mental illness is not a sign of weakness or a fault in character. Mental illness does not discriminate, and under the right conditions, any one of us could develop one. Now, decades of research has found several factors contribute to the development of serious mental illness, most giving the person little control over its onset. Some of the main areas that are linked to the development of serious mental illness are genetic or biological factors. Maybe someone has a family history of particular diagnosis. Environmental factors. This could be something like a history of trauma or abuse. Socioeconomic factors and major stress, things like poverty or death of a loved one. Medication and disease can also induce the onset of mental illness. It's been found that people with chronic medical conditions like cancer and diabetes have higher rates of depression. Next slide, please. Now, studies are showing some interesting trends around the prevalence and care of individuals with serious mental illness in nursing facilities. It's estimated that as many as 30% of the nursing home population has a diagnosed mental illness. This is a 19% rise over the last 2 decades. About 150,000 individuals with serious mental illness now reside in nursing homes, which is the equivalent of the entire supply of inpatient psychiatric beds across the US. Individuals with serious mental illness are more likely than adults without serious mental illness to spend time in a nursing facility, with Medicaid beneficiaries with schizophrenia being 4 times more likely. Individuals with serious mental illness are more likely to be admitted to facilities with poor quality of care indicators, including higher rates of rehospitalization and untreated pain. In nursing homes, most new admissions with serious mental illness are younger than the age of 65, which has created a really unique subpopulation for nursing facilities. Now, take a minute to reflect, how do these trends line up with what you're seeing in your communities? Next slide. So why is understanding mental illness so important for nursing facilities and their staff? Not only for regulatory reasons, but for patient care. Unmanaged serious mental illness has far-reaching impacts on residents' overall health outcomes. People with serious mental illness have significantly poorer health outcomes than the general population. It's been discovered that people with serious mental illness die 10 to 25 years earlier than patients without these illnesses. Also, those with serious mental illness have more comorbidities related to physical health conditions and a poor prognosis for those conditions than those who do not. Another study found higher 30-day readmission rates for people with serious mental illness and the comorbidities related to diabetes, cardiovascular disease, and COPD. Now, mental health and physical health go hand in hand. Next slide. We'll start with the schizophrenia spectrum, which is becoming more prevalent in nursing facilities. Millions of people across the US suffer from schizophrenia. The typical onset for women is between the early 20s to mid 30s, and the typical onset for men is late teens to early 20s. It is extremely rare for there to be an onset later in life. Symptoms of schizophrenia vary greatly from person to person and can change over time. Schizophrenia usually involves delusions, also known as false beliefs, and hallucinations like seeing or hearing things that aren't there. They may have unusual physical behavior and disorganized thinking and speech. It's common for people with schizophrenia to have paranoid thoughts or hear voices. For example, they may believe that someone is controlling their thoughts or planning to cause them harm. These psychotic episodes are often just as scary and confusing for the people experiencing them as they are for those around them. Now, schizophrenia can be extremely disruptive to a person's life, making things like work or keeping a schedule, socializing, completing daily tasks, or taking care of oneself much more difficult. With consistent treatment, a combination of medication, therapy, and social supports, people with schizophrenia can manage the disease and still live fulfilling lives. Next slide, please. Next, we have bipolar disorder, bipolar and related disorders. These affect millions of adults throughout the country. Most people are diagnosed with bipolar in their teens or 20s, but this can occur at any age. There seems to be a strong genetic component to bipolar disorder, and people are at a higher risk if they have a family history or have experienced traumatic events, or a history of drug and alcohol misuse. Research has also found that there are identifiable differences in the brain structures of people with bipolar disorder. Each type of bipolar disorder includes high periods of mania and low periods of depression. There may also be times where the person feels stable. The major difference between the three types of bipolar-related disorders is how extreme the mood states are and how long they last. Next slide. The primary feature of bipolar-related disorders are the unusual shifts in mood. When a person has a manic episode, they may feel overly excited, productive, or even invincible. In contrast, when a person has a depressive episode, they may feel extremely sad, hopeless, or tired. They may avoid friends, family, and participating in their usual activities. A resident with bipolar disorder in a depressive and a manic episode will typically have noticeable changes that shift from their baseline behavior, appetite, sleeping patterns, motor skills, energy levels, and decision-making capacities. A severe manic or depressive episode may trigger psychotic symptoms, such as delusions or hallucinations. And while bipolar disorder is a lifelong diagnosis, and the signs and symptoms vary from person to person, many people find ways to manage their symptoms successfully through medication and evidence-based therapies like cognitive behavior therapy. Next slide. Now, depression affects more than 20 million people in the US. A person has an increased risk of depression if their family has a history of depression, if they have experienced trauma, major life changes, stress, or certain physical illnesses, such as diabetes, cancer, or Parkinson's. Depression can also be a side effect of some medications. The way residents present with their diagnosis will vary. Like the depressive episode we spoke about in the previous slide, caregivers may notice changes in residents with depression by changes to their behavior, appetite, sleep patterns, motor skills, energy level, and decision-making abilities. There are several screening tools that facilities can use to monitor depressive symptoms, and the most common being the PHQ-2 and the PHQ-9. There are some evidence-based treatments for depression, which includes an evidence-based therapy like cognitive behavior therapy and medications. Next slide. Experiencing the occasional anxiety is normal, but residents with anxiety disorder tend to frequently have intense, excessive, or persistent worries or fears about day-to-day situations. When severe, these feelings of anxiety and panic can interfere with their daily activities. People who suffer from anxiety may go to great lengths to avoid the places and situations to prevent those feelings. The typical onset can happen anytime during a person's life. An anxiety disorder may be triggered by something environmental or biological factors. And interestingly, heart disease, diabetes, and COPD have all been linked to the development of anxiety disorder. Symptoms of an anxiety disorder can be both physical, like sweating or rapid breathing, or they can be internal, like an impending sense of doom or danger. And there are several tools to screen, several screening tools that facilities can use to monitor anxiety, and one of the most common is the GAD-7. So there are two main treatments for anxiety disorders, cognitive behavior therapy or exposure and response prevention therapy, along with medications. Next slide. So obsessive compulsive and related disorders typically feature cycles of unwanted, intrusive, and persistent thoughts known as obsessions, which causes distress to a person that drives them to perform rituals or actions to ease that distress. So some common obsession-related themes are cleanliness, uncertainty, orderliness, losing control of oneself, or unwanted thoughts. Compulsions typically have some common themes as well, like washing, cleaning, checking, counting, or following a strict routine. The severity and impact of these symptoms vary from person to person. And there are two main treatments for obsessive compulsive disorder, and that would be cognitive behavior therapy or exposure and response prevention therapy and medications. Next slide. Trauma and stressor-related disorders are mental health conditions that develop as a result of a traumatic experience. One thing to note is that a traumatic experience does not always result in a trauma-related disorder. Trauma itself is very subjective, and because we all have different backgrounds and experiences, what traumatizes one person may not traumatize another. Trauma and stressor-related disorders can develop immediately after someone is exposed to extreme stress or trauma, or much later. There's no timeline to the effects of trauma. It's been found that some events tend to result in trauma disorders more than others. Things like violence, neglect, abuse, losing a loved one, witnessing abuse or violence, torture, being in an accident, losing a home, serious illness, as well as natural disasters. Trauma affects people of all ages and all genders. There are two main treatments for trauma-related disorders, which is an evidence-based therapy like cognitive behavior therapy or cognitive processing therapy, and sometimes medications. Next slide. The last disorder that we will cover is dissociative disorders. Now, most people from time to time experience some mild level of dissociation. Think about daydreaming or zoning out while you're driving. While these examples are mild, residents with dissociative disorders experience a serious loss of connection between thoughts, feelings, memories, surroundings, behavior, and their identity. Like trauma, dissociative disorders usually arise as a reaction to shocking, distressing, or painful events in someone's life. Stress tends to worsen their symptoms. Some common symptoms include depersonalization, which involves a sense of separation from themselves or feeling like they're outside of their bodies, or derealization, which involves feeling that other people or things are separate from them or altogether unreal. Surprisingly, there's no recommended evidence-based treatment due to how rare these disorders really are in the limited sample size when doing research on treatment. With that being said, therapy with a trauma-experienced therapist and a psychiatrist is recommended. Next slide, please. So there are many types of therapy available for a resident who would like to work on their issues or get support for their serious mental illness. Certain types of therapy may be more effective for some conditions as opposed to others, and evidence-based treatments are always the best practice. So we have animal-assisted therapy. This is a therapeutic intervention that incorporates animals such as horses, dogs, cats, birds into their treatment plan. There's cognitive behavior therapy and dialectic behavior therapy, which are two types of talking-based therapies that aim to manage problems by changing unhelpful patterns of thinking that may lead to problematic behavior. We also have mindfulness-based therapies, which help focus your thoughts and feelings focus on your thoughts and feelings as they happen, moment by moment. There's EMDR, which works to help the brain reprocess memories of traumatic events so that those negative images, emotions, and physical feelings cause less impact to someone. There's exposure therapies, and these are a type of behavioral therapy designed to help people face their fears. And then lastly, I find that group therapy is one of the most underrated therapies that there is. It has such wide application to many different diagnoses. And these are usually run by a licensed mental health professional. Many of the groups are designed to target a specific problem, such as depression, obesity, panic disorder, anxiety, chronic pain, aging, substance use disorders, and so much more. Next slide. Now, where do we begin on an individual level supporting residents with serious mental illness? First, be curious about your resident. Don't assume that you know someone based on their diagnosis. Get to know them as people. We want to also use person-first language, which is a best practice. Person-first language puts the person before their diagnosis. So for example, you wouldn't want to say Mary is a schizophrenic. You would want to say Mary has schizophrenia. Residents have a diagnosis. They are not their diagnosis. And next, you want to educate all your staff, not only direct care staff, but all staff within your facility. Throughout the day, your residents are interacting with countless people, housekeeping, dietary, volunteers, contract providers. All of these people should hold a basic knowledge about serious mental illness to best care for your residents. We also want to get to know your resident triggers and their go-to coping strategies. So have these documented somewhere for your team so they know how to support your residents, and include your residents when creating these lists whenever possible. We also want to involve residents in their care whenever you can. The best laid plans fall to pieces when residents aren't on board with the behavioral health services that are coming their way. We also want to be consistent. So residents with serious mental illness benefit from consistent, predictable routines. Allowing room to make as many choices as they can throughout their day is also important. Allow residents to make choices. This gives them some control back when residents have much of their day dictated by other people. And lastly, have strong boundaries. Boundaries are healthy, and when caring for people in a long-term care setting, which is also their home, it can sometimes blur those healthy boundary lines. Next slide, please. So treating serious mental illness in a nursing facility can be complicated. You have a whole list of other things that may take priority in basic care for residents. With that being said, I challenge you to prioritize mental health and watch your resident health outcomes improve. There are several ways to get behavioral health counseling into your facility. Things like in-person or virtual counseling, support groups, peer support groups, and 12-step programs are a really good place to start. We also want to make sure residents have access to the providers, to the specialized providers and medications that may be helpful in treating their mental illness. We want to make sure that there's good staff education, which is imperative in caring for residents with serious mental illness. Look into mindfulness and self-regulation trainings for your staff, de-escalation skills, specific diagnosis education. Maybe this is through a formal training or short one-on-ones or in a small group training during weekly meetings. And lastly, resident voice plays a huge role in supporting residents with serious mental illness. Include them whenever you can in their care plans and debriefings after incidents related to serious mental illness. Maybe look into advanced psychiatric advanced care directives as a tool you can use for residents with serious mental illness to give them a voice. Next slide. So as we wrap up, a serious mental illness is a mental illness that interferes with a person's life and ability to function. Serious mental illness is not a choice, a weakness, or a character flaw. It is a result of genetics, biology, environment, trauma, abuse, medications, or even disease-induced. And while serious mental illness can only be diagnosed by a mental health professional, nursing facilities play a pivotal role in the lives of residents with serious mental illness. And much like serious mental illness, addiction and substance use disorders are also not a choice or character flaw. And this will be covered more in our next session. And as we close this portion, we'll move to some time for some questions. And thank you so much for your time today. Next slide.